Buongiorno a tutti, c'est un grand plaisir pour moi d'introduire Suzanne Gard. Elle travaille au CHUV de Lausanne. Elle travaille surtout avec les sportifs, les adolescents sportifs. Elle est aussi à l'AES à Genève comme enseignante et elle va nous parler de la hypermobilité dans le sport. Je te donne la parole. Merci beaucoup.
So I chose to talk in English, so excuse my English. So don't forget at the beginning of my presentation to answer the 2 survey questions I put. At the right-hand side of your screen, you can answer the poll questions. So what an honor for me to speak at this all-woman speaker symposium. Thank you, Sports Physio, for your kind invitation. I chose to talk about hypermobility in sports. Is it a blessing or a curse? This talk is based on my clinical observation. First of all, I'm very confused. I was very confused with the classification of hypermobility, spectrum disorders. I think it's really confusing. And my question was, is it very frequent, or do I see a lot of those patients? And the second question was, are they more prone to injuries? So that's my 2 survey questions that maybe I would like your opinion on these 2 questions. I understand that hypermobility is certainly necessary in order to perform in some sports. And I saw that my injured patients with hypermobility spectrum disorders are struggling in the rehabilitation. So there is a consensus about how we should call these disorders. So if you speak of generalized joint hypermobility or Ehlers-Danlos syndrome, you can say it's in the hypermobility spectrum disorder. And this hypermobility comes with all shapes and shades. So I hope I don't lose you here. It's a very, I love figures. So I took this one, I adapted this one from the article from Castori et al. The blue big box is circle is about general joint hypermobility asymptomatic. So these people don't have any complaints. They're just very bendy, windy people. And inside of it, you can see that there are some generalized joint hypermobility syndrome. These are people that suffer from this particularity. And you can see on the pink big circle, this is Ehlers-Danlos syndrome. This is really trendy at the moment. In Lausanne, we do a lot of genetic tests about this disease, and they have a waiting list. And in this family, there is hypermobility Ehlers-Danlos syndrome, which is a small part of EDS. And you can see at the bottom, you have these are articular complaints, hypermobility spectrum disorders. You can have only peripheral hypermobility in the peripheral joints, especially the feet. And you can have localized hypermobility, so only maybe in the knee or maybe in the shoulder also. And you can have historical hypermobility. That means that before you had hypermobility, but now it cannot be expressed because you develop some stiffness around your hypermobile joint. So it can be a bit confusing too. And you can see at the upper half of the screen, they can suffer from extra-articular problems, such as psychological distress, pelvic and bladder dysfunction, postural orthostatic tachycardia syndrome, and functional gastrointestinal disorders. So the big difference between general joint hypermobility and EDS is with the presence of history in the family and also skin disorders. We will see that later. So I like table 2, so I can show it in a table. Maybe it's more easy to understand. How do I make the diagnosis of this? So the common symptoms of general hypermobility are joint instability, recurring sprains, strains, joint subluxation, dislocation, and muscle tension pain. And you can see in the blue sector, so these are asymptomatic people. So they have no complaints in MSK, as you can see on the right-hand side. And the Batten score might be positive in generalized joint hypermobility, but they have no complaint. So we skip to the violet lines. So they have, these are people that have symptoms. And you can see that in generalized hypermobility spectrum disorders, they have positive Batten score, of course, and they have also the presence of complaints, musculoskeletal complaints. And at the bottom in pink, you have the syndromic, comprising the hypermobility, Ehlers-Danlos syndrome. They have positive Batten score, and they have possible MSK involvement complaints. So Ehlers-Danlos syndrome is have 13 related heritable connective tissue disorders. So it's mainly joint and skin manifestation. The skin texture is very soft, velvety, and but can be also normal. And the skin properties are stretchy, so they can stretch their skin really easily. And it's also a fragile skin that is tearing easily and with the delayed wound healing. The genetic cause is unknown, so we have no genetic test for Ehlers-Danlos syndrome hypermobility. So the diagnosis is established only on clinical basis only. Okay, so if you want to resume that the hypermobility ADS is predominant joint hypermobility without obvious clinical findings of a more specific diagnosis. So here are all the classification of EDS, and you can see in pink the hypermobile EDS, and as I said before, the gene is unknown. And all the other EDS, you can really make a genetic test, and you can confirm your diagnosis, but not with the hypermobility EDS. So how do we do? So if you want to know more, you can go into more details with the 3 articles. They're really good. So first of all, the first point in the clinical diagnosis is the Batten score. So you see that we have values that are different for prepubertal children and adolescents. It's positive only if it's above 6 out of 9 points. And for pubertal men and women under the age of 50, it's positive if you are equal or above 5. And for men, it's and women over the age of 50, it's positive if you have equal or greater than 4. Okay, so the Batten score, I guess everybody knows what it is. It's 2 points for the pinky finger and 2 points for the thumbs, 2 points for the elbow, 2 points for the knees, and 1 point if you can touch the ground with your both hands flat. How does it go into the diagnostic criteria for hypermobile EDS? So you have the first criteria is the Batten score. So if it's 1 point below the age-specific and sex-specific cutoff, and you have 2 answers to the 5-point questionnaire in pink, bright pink, then you can make the diagnosis of generalized joint hypermobility. So can you now, or could you ever place your hand flat on the floor? This is really important because, as I said, you can have a historical EDS. So that means that maybe you were hypermobile and you built like a fortress around your joint, and you're not hypermobile anymore, but maybe you could, as a child or as a young, amuse your friend by dislocating your shoulder, for example, or as a child or teenager, did you have some dislocation, knee and shoulder predominantly, or do you consider yourself double jointed, as you had a second joint? So if a yes to 2 of these questions suggests joint hypermobility with 80 to 85% sensitivity and a lot of specificity also. So this is quite good. So this doesn't make Ehlers-Danlos hypermobile. This does. If you have systemic manifestation of other tissue disorders, for example, skin, if you have a positive family history or musculoskeletal complications, if you have this, you can say that probably it's a hypermobile Ehlers-Danlos syndrome, and you have to meet all the criteria on the right side of the screen, which excludes other systemic syndromic conditions. Before going to the next slide, I would like to see what you answered to the frequency question. So I don't know if I can have the result of the poll. Yeah, that's good. How common is general joint hyperlaxity in the general adult population? You answered between 10 and 15%. And half of you thought that. So let's see what the literature says. So I go back to my screen. Yes. So between 12 and so it's between 10 and 15%. So half of you were right. It's for adults, it's about that. And among children and adolescents, which was not in my question, it's 34%. We lose hypermobility with time. What about the prevalence of Ehlers-Danlos syndrome? That was a survey that was made in the UK, in Wales actually, and you see the big numbers of individuals they question, and it's about roughly 10 cases in a practice of 5,000 patients. So it's quite frequent. So before going to the next slides, I would like to have your opinion on do they get more injuries, these hypermobile patients? So I don't know what you answered. Yes, okay, that's a big yes. So you think athletes with the hypermobility do have more injuries. So let's see what, I brought this question on Facebook and Twitter, and I had, this was more mitigated. Like we had a yes, but it was not a strong yes. Most people were hesitant about the answer. So what does say the literature? Let's see. According to the literature, no effect on injury risk in elite female soccer player. Okay? No correlation between hypermobility and injury rate in artistic gymnasts. No correlation in dancers. So no increase either in sports injuries, and no significant difference of injury. So we can see that although we have this impression, it's not true. But this was very general. And we can see that at the knee, it's certainly more, they're certainly more prone to injuries if you take one joint. So this survey reported twice more likely to report joint-related symptoms with people with knee hypermobility or with general joint hypermobility. What about the shoulder? You know that my shoulder is my favorite joint. So you have in shoulder, you have 3 times higher odds to have shoulder injuries. Probably because it's an unstable joint, kind of. And also the knee is the same. They rely a lot on passive structure for stability, I guess, these 2 joints. And a very interesting study in swimmers related that strength, people with patient with hypermobility related strength and fatigue deficits in medial rotation in swimming. So you see the medial rotation is really important in swimmers, and they have this fatigue and strength deficits. And also another study reported that they could see pectoralis major activity in swimmers was altered. Once again, the pectoralis major was not working very well. And usually we tend to want to increase more the strength of the external rotator, usually when you have shoulder injuries. But with this patient, we must think differently, and maybe it's important to strengthen the internal rotators also. Don't forget them, because otherwise you will get in trouble. So that's interesting point of view for these patients. So as I said before, I'm well aware that it's an advantage in some sports that you don't qualify if you're not flexible enough. There is in dancers there is a very high prevalence of hypermobility. But what is striking to know is that young dancers have a lot of hypermobility. When you talk about first ballet dancer, they don't have that so much, which means that probably the other very hypermobile ones, maybe they don't succeed up to the top level. That's just a thought. And there is selection assets in other sports like gymnasts, divers, hurdlers. You can name a lot of them in swimmers also. So how can I help? So there is no evidence-based medicine literature on good quality on rehabilitation as often, but especially with this population. And so we need education, not only for maybe the patient, but also for the health professionals. And usually what does the literature kind of tells us without evidence, strong evidence, that there is moderate evidence that close kinetic chain exercise are very well received by this population because it gives you a more proprioception on your joints, and also that balance and proprioception. Balance is altered in hypermobile patient. We will see that later, and probably working on balance is a good idea. And strength and conditioning is a good idea anyway for any musculoskeletal complaints. And you need to have a cognitivo-comportamental approaches because we will see later on there is more anxiety. This population is more sensitive to anxiety. So pain, what about pain with hypermobility spectrum disorders? It's often widespread and long-standing, and it mismatches a lot with the way the patient looks or move. They look pretty good, they move a lot more than me, and they seems well. And so patients are misunderstood. They talk about this pain they have in their muscles all over their body, and it's sometimes they're very often misunderstood. And a lot of those patients suffer from shoulder function, increased pain intensity and control on the shoulder, and they have both specific painful joint and also generalized pain. So they are chronic pain patients very often. The proprioception, so they have balance deficits. You can measure them either very eyes closed, eyes open, Romberg test, but you can also use platforms, and you can then measure the increased postural sway, and they have a lot of more sway. And proprioceptive training, really simple, like, exercise we do in physio for lunges, squats, or exercise with the SABT or something like that. Very simple training. They do improve symptoms, and it has been proven in this population. What about the quality of movement? That's really difficult. But a good question you can ask, is it normal range of motion for them? Because for you, it might appear a normal movement. For them, no. So it's important to relate to what they feel, really. And if they have complaints, you can look for muscle imbalance, relative joint stiffness, poor motor control, because they can have a really stiff joint, but maybe they're protecting this hypermobile joint. So you must be very aware of that. And they usually use altered recruitment patterns. Anxiety and hypermobility, there is a strong association between anxiety and hypermobility spectrum disorders. The study by Shepard showed structural brain changes that enhance the vulnerability to stress and anxiety. So I guess psychological monitoring is needed with this patient. What about surgery? I only took one article that refers to the fact that very often they have inferior biomechanical properties of the collagen. They have anxiety, and we know that anxiety is not a good outcome predictor of surgery. They have a lack of proprioception, so we must be sure to do a very good pre-surgery preparation on that, and they have longer recovery time and potential complication with EDS. So a good conversation would be to recognize they have hypermobility prior to surgery and discuss with them all the complications that can occur, all the difficulties. And if you can not operate on them, it's even better. So I love qualitative studies. So I guess in this focus group study of patients, they did some interviews with health professionals and patients. And the first thing is that health professionals are very skeptical sometimes. And they can say something like, it's something psychological, and you just need to be a bit braver. Or I don't believe in hypermobility. And there is still a quite prevalent view that it's all in the minds. So that really struck me. And so this patient says, I think actually it's the health professional that need education. I mean, there's a lot of things I still need to know about hypermobility, but on the flip side, I do think it's the health professional that needs to know more. So I think that's very wise. We need to know more to understand better these patients. And The second quote was, I was originally seen by a physio who hadn't diagnosed with the hypermobility, and then I went back to a musculoskeletal specialist, then put me forward to a specialist in hypermobility, and since then it's been amazing. I think it's been worthwhile, and see. So it's all about referring to the people that knows a little bit more about this disease, or to educate yourself and try to know more about this. And then the time to diagnosis is really, really critical, because by the time they come, there's quite a lot of psychological baggage, and they're a difficult patient. The fact to have such debilitating joint is making you mentally unwell, and they're suffering from severe pain. So I think the more early we see them, the better it is. And it's all about managing expectation. I don't think we can... They can be great all the time. They have to live with this condition, and I think it's good if they understand that they can manage this, they can do with the hypermobility. And you have to give them the keys to do well with the hypermobility. And you may not expecting them to get pain-free, but you know what you do to manage it, then you're there. So I think the success is to understand that it's just a condition to manage. There's a study on the Mobilex study that is going on right now. It compares 16 weeks of progressive heavy shoulder strengthening, and general advice, compared to low training and general advice. On this population. Why did they do that? Because very often we tend to load them less to alleviate their symptoms, and they are studying if we should not load them more, maybe. So that will be interesting, but the study is not, it's only the protocol, so it's not done yet. So as a take-home message, I think early diagnosis is important, education for all, and you need a holistic approach. So you can see there are many systems involved, so you have to be really keen on looking at all these features. And we need more research for PT intervention, because I didn't find any good conclusion, firm conclusion, but waiting for that, we can still go for education, close kinetic chain exercise, balance and proprioception, strength and conditioning, and cognitivo-comportamental approaches. And I hope to see you in Nyborg for the next World Congress of Sports Physiotherapy in 2022. It will be 26 to 27 August in Nyborg, Denmark. Thank you for your attention.
Thank you, Suzanne. It was very interesting. Please, you can make your question. If we don't have questions now, but maybe I can make your question, because you are working with a lot of people between 11 and 20, and often these people are very motivated in sports, but on the one side they have the coach, he wants more, and on the other side maybe is you say no, now you have to go a little bit calmer. How do you manage this situation with these young people, with the family maybe, or?
Yeah, well, we have to side up with the young, of course. We have to protect them. Yeah. So that's the main priority. I don't think it's worthwhile to be a world champion at 12. I think we need to make the coach and the family understand that it's a long-term that we want investment in sport. Sometimes it's good to take a step back, but I tend to encourage them to go as soon as possible, at least at training, or one part of training because, sports is their second family. So it's really hard not to see your half of your family if you would know. So it's good for their morale, but you have to be careful about not pushing too hard because then you will destroy these young people.
The good feeling, the
Yes,
sensibility.
yes.
Fine. I'm looking.
We don't have questions.
We don't have questions.
So it was very clear.
Yeah, you made it very clear, and maybe they are all hungry.
Yeah, maybe.
So now we can make the break. Wir können die Pause jetzt starten und wir werden uns wieder 15 Uhr treffen. On fait la pause maintenant et on se voit encore à 3 heures ici. Bon appétit!